Well, thank you everyone for inviting me back. It's always a pleasure to come back and speak to the same group. Now, what I typically speak about last time was TMJ disorders, head, neck, and facial pain. I gave my basic presentation last time, but tonight I feel I'll speak on implant prosthetics and occlusion as it relates to all of our practices. And pretty much I developed this only because of what I've been seeing in my practice from other practices as well. So our outline tonight is occlusion in dentistry, implant protected occlusion, TMJ and bruxism, and implant restorative options. So no matter what aspect of dentistry we practice, it has to deal with occlusion. All right? Occlusion is a very important part of all of our practices, and dentistry really is all about occlusion. And we know that the starting point of a stable occlusion really is the TMJ. Of course, this is my bias, but this is the foundation. So the starting point of a stable occlusion really starts with the foundation, which is the TMJs. We know that unstable joints can lead to unstable occlusion. And if the TMJs are not stable, even our best dentistry may fail. So we have to have a stable foundation. I tell our patients, it's like if you're going to build a house, who cares about the roof? You have to make sure you're on a solid foundation. You're not going to build your house on quicksand. To illustrate this, if we look in the center, that's what a normal TMJ would look like, a very stable TMJ. And this particular patient had osteoarthritic changes or condylar cortex breakdown and joint dimension loss and unstable joints, and she manifests in a premature contact. So the occlusion does change because of the instability within the TMJs themselves. So our goal in practicing is to have complete harmony between the teeth, the muscles, and the joint. So tonight I want to talk a little bit about implant protected occlusion and implant restorative options as well. Now, before we diagnose and treatment plan any patient, whether it's for a single unit crown, a two-surface amalgam, we have to understand how the restoration may fail, or what can make our restorations fail. Well, the same applies with implants. We must know how implants can fail. So there are three reasons why implants can fail. Number one is lack of integration. For whatever reason, the implant is placed and it doesn't integrate for whatever physiological reason. Number two would be loss of integration. The implant is integrated, it's fully restored, and then it fails. And number three would be structural failure, right? Broken and loose implant components, right? But you could see that two of the three ways an implant could fail has to do with occlusion and occlusal overload, and this is what I want to speak to you about. And of course, this has been repeated in many other studies. Implants are failing, and the factors conducive to implant failures really have to do with occlusion itself. So with implants and occlusion, what do we really need to know? We need to modify our thought process when we're adjusting occlusions on an implant versus natural teeth. And that's why Carl Misch came up with the implant protected occlusal scheme. This reduces occlusal load on the implant itself. Very, very important. Now, I see a lot of patients for TMJ disorders and head, neck, and facial pain, and of course I always check their occlusion. So that prompted me to develop this topic for us. And of course this has been repeated and proven that complications of occlusal overload on the implant can really lead to peri-implant infection, screw loosening, prosthetic failure, and implant failure itself. So in the implant protected occlusal scheme, we create an environment to decrease the stress to the bone, to decrease the stress onto the implant body and prosthetic components. So there's two types of occlusal schemes that we practice. One is the most common, really, is the single tooth or partial arch scenario, where we have the implant surrounded by natural teeth. If you have an implant in area number 30, but you have 28, 29, and 31 of natural teeth, right? It's sharing the load. It's sharing the load. And of course, then there's the full arch scenario where the implants provide all the 5 occlusal variables. Right, so we're not going to focus much on that at all tonight. Now with natural teeth, due to the periodontal ligament, the teeth have 2 types of movement when we bite down, primary and secondary movement. With primary movement, when we bite down and we generate a force, right, that movement of the root goes within the periodontal ligament. It's sudden and rapid. Right? You bite down, the tooth moves within the periodontal ligament. Then over time, there's secondary movement, all right, where that movement is into the root goes into the bone. That's slow and minimal. That's over time. Now remember, implants do not have a periodontal ligament, so an implant would only have secondary movement and not primary movement. So let's look at this and let's compare. With natural teeth, under primary movement, under vertical load, it moves 28 microns, and all the force pivots towards the tapered apex. So you bite down on a natural tooth, all right, and it depresses 28 microns, and all that force goes towards the tapered apex. With an implant, though, it's secondary movement. When you bite down, all that vertical load goes 5 microns only, and the force to the crest of bone, not the apex, to the crest of bone. Very, very different. Very different. Now, this is very critical for us to really understand as general dentists. These movements occur whether you bite down hard or gently. Now, the teeth do not rebound immediately. So if you bite down on a tooth and it depresses, it doesn't rebound immediately. It can take up to 6 hours. So if you're adjusting occlusions or you're checking your dentistry and you have them bite and bite and bite and bite, and it's different each time because that tooth is depressed, it is not rebounding. All right? So we have to pay a lot of attention to occlusion. I think most of us learn it, but I think we're not paying attention as we should. So these are principles that we have to keep in the back of our mind. So with primary movement, when we generate a vertical occlusal load on a natural tooth, all the force will go down to the tapered apex. And with secondary movement, we generate a load to an implant crown that's to the crest of bone. Very, very different. So we all must understand the basics of occlusion, then implant occlusion in terms for our implant longevity and for our longevity alone. So I always, when I talk to my residents, I always say, have this picture in your mind that we want lines in the front and dots in the back. Now this is what we were taught in dental school. This is the way we really should practice. And what does that really mean? What does it really mean? Dots in the back, okay? So when you have dots in the back here, we want the force of the occlusion down the long axis of the tooth. When we bite down, we want all the force down the long axis of the tooth, whether it's a natural tooth or an implant. What type of contacts will actually load teeth? Well, it's a point against the flat plane. We know that. We have to practice this. This is something that we've been taught. Point contact against the flat plane. Right? So when we're creating our occlusions, whether we did an MOD composite or a crown and we're creating our occlusion, we want to make sure that it's a point contact against the flat plane, either on the marginal ridge or in the central fossa in this particular case. So axial loading is when the force goes down the long axis of the tooth and the periodontal fibers can resist those vertical forces evenly. So right down the center, there's no stretch and no strain of the periodontal ligament fibers. On an implant, we want to make sure that the center contact is over the implant body itself. The contact needs to be over the implant body itself, and that provides uniform compression along the implant to bone interface. Okay? So what type of contacts do not actually load teeth? Well, any contact that's not perpendicular to the axis or an incline contact. Contact on an inclined plane, which we see all the time. So even though that force is a vertical direction, it will provide a lateral force transferred to the tooth. So we want to identify these incline interferences and eliminate these incline interferences. When I teach my residents, I say, do not ever, ever equilibrate teeth. They're not ready for that, right? But if you must equilibrate a tooth, just reduce any incline interference and you will do no harm. Now when you have an incline interference, you would get a hit and slide, all right? So we hit and slide, and that causes lateral forces on the teeth themselves. So we need to identify and eliminate any incline interference, and that's a non-axial load, all right? So what happens when we have an incline interference? On natural teeth, all right, we'll have symptoms because of the periodontal ligament stretch, all right? We'll have symptoms, hot, cold, air, sweets, PDL stretching, which we could see. We'll see wear, we'll see hypermobility or mobility of the tooth. On an implant, that would increase load to the bone itself. And this is in our literature that non-axial forces will create a stress and compression to the implant bone interface. So we have a case here where we have incline interferences, all right? An incline interference on an implant crown. And that can create problems with the crest of bone. This is an actual case, all right? This is an actual case. And we see this all the time when I check occlusions. This is an implant crown, but yet we have a non-axial load. We have non-axial contacts that must be eliminated. So the implant-supported restoration must be equilibrated differently than the adjacent teeth. It's not the same. There's no periodontal ligament fibers. All right, we know all the forces that go down the tooth versus the forces that go down the implant, so we can't equilibrate it the same way. So I want to go over the technique very quickly with you, what we do. When I address occlusions, when I check any occlusion, most of us will take that articulating paper and you'll have one side and you have them bite down. I never do that. We have to check using both articulating papers. I use the articulating forceps and we check both sides evenly, either in an MIP position or in a position where we guide and fully seat that position. Now remember, whether you bite down hard or gently, the natural teeth do not rebound right away. Right? Very important concept for us to understand. When you go home tomorrow and you start practicing and you look at your occlusions, I want you to think about that. So the technique really is this. The first thing we want to do is we want to dry the teeth, all right, with gauze. All right. Now we create a light contact. I use 20 micron paper. Actually, I use ribbon, the AccuFilm 2. We contact all the teeth, all right, with this light 20 micron paper. Now, the natural teeth have depressed, okay? Remember I said they'll depress. The next thing I do is eliminate the occlusal contacts on your implant crowns, okay? So we mark all the teeth and we eliminate the contacts of the implant crowns. Now the second thing we do is create contacts with heavy paper, the Bausch 20 micron, 200 micron, okay? Now we're creating that contact and now we're going to eliminate all the excursive interferences of the implant crown itself, and we really do not want any lateral forces. So that's the implant occlusion, all right, scheme. Let's think about that. Let's look at this. So, okay, under light contact, we contact all the teeth. The natural teeth will depress. I eliminate the contact off the implant crowns. Okay. Now we put our heavy paper in and we have them bite down, and we distribute the contacts evenly, and we eliminate any other contact on the implant crown except that one contact that's right over the implant body itself. So we want to center that contact over the implant body. That's the only contact that should be present on an implant supported crown. Okay? And no lateral forces whatsoever. So here it is. Okay? So that's an axially load tooth. All right? With the axial load, all the forces are down, right down the center of the tooth, and you should be able to distinguish between the two. Okay? So that's what the occlusal scheme should be like. Then we call that the functional fossa. It may be in the center, it may not be in the center, because if the implant is a little to the distal, then we want that functional fossa to be on the distal, not in the central part of the crown itself. Now what I see a lot is that we place our implant crowns in and they're not in occlusion at all. You put it in, you have the patient bite down, oh yeah, that feels good, doc. Yeah, but you're not biting on it at all. Is that appropriate? I've had many patients come to me with almost a full arch of implant-supported crowns that do not contact, and they wonder why they have a TMJ problem. And, well, it's like walking around with one shoe on and one shoe off. The whole left quadrant's not contacting. Okay, send it back to the dentist and say, okay, we have to address that. All right, so that can cause occlusal traumatism on the natural teeth in the same arch itself. Now let's get back to our basics. Okay, we said, right, dots in the back, right, lines in the front, but we don't want any lines in the back. Right? We have to eliminate all the lines in the back. This is not appropriate. These are non-axial contacts, whether it's on a natural tooth, a crown, or an implant-supported crown itself. Now we know that anterior occlusion in dentistry is very different than posterior occlusion. By the way, this is a very cut back version of the lecture I give because of time. All right, this is I do a very, very detailed presentation on this, but I cut it back quite a bit. But we know that anterior occlusion is very different. All right, what we're trying to do with our anterior occlusion is to reproduce the condylar guidance with the incisal guidance. Condylar guidance with incisal guidance. Right? When we perform our anterior occlusal scheme, our anterior crown and bridge. Now we know anterior occlusion is really joint based. Here's my bias again, right? Everything is joint related, right? But we know that if you're losing dimension within the TMJs, if you're losing condylar dimension, right, and you're on retrodiscal tissue, we know that condyle can not only lose it, become more vertical, it can become more horizontal, and the condylar inclination can actually decrease. So yes, condylar inclination does change over time, and that's why we have to pay a lot of attention when we do our anterior occlusal schemes with anterior crown and bridge, right? And I think most of us are getting away from the articulator, but I think we should get back into the articulator. And I talk to my residents, no one should do any anterior occlusal dentistry without understanding condylar guidance and incisal guidance and reproducing that with the actual articulator. That's the only way to do it. We can't use those hinge type of articulators where our condylar inclination is not 0 degrees. It may not even be 20 degrees. So we want lines in the front and dots in the back, okay? So we see this all the time, and which this is what we try to create. So now getting back to an implant crown, a posterior implant crown, we want a posterior disclusion, right? It's in our literature, right? That the implant, we could reduce the force on the implant with proper anterior guidance. So we want to eliminate all working and balancing interferences on the occlusion, right? And by doing that, sometimes we have to eliminate the cuspal inclination. We make the crown flatter. We don't need these big cusp tips, okay? So yeah.
What if you have a canine?
Coming. Good. It's coming. Give me a few slides. All right, good for you. Thank you. This happens every time I speak. There's always somebody that's way ahead of me, and that's great. I appreciate that. Good for you. It keeps me on my toes because sometimes, if it's not part of my presentation, I put it in for the next time, so thank you for that. So here we go. We want cuspid rise, all right? We want cuspid guided disclusion. And really the literature is very strong on that, okay? In that we want to have cuspid rise and cuspid disclusion. And with EMG studies, it's been proven that when we have cuspid disclusion, cuspid rise disclusion, the masticatory muscles actually decrease. So the firing of the masticatory muscles are reduced. So what happens if you have a canine implant, a cuspid implant? Okay, very good. All right, so we want our lateral guidance to be shared with the anterior teeth. That's true anterior guidance. So we're not riding just off of the cuspid. We're riding off the cuspid lightly, but really shared with the anterior teeth. That's true anterior guidance. I don't know what happened. Will your implant-protected occlusal scheme remain stable or develop premature contacts? Will it remain stable or will it change? All right? So, will this happen? All right, you develop the implant occlusal scheme and then all of a sudden some things change and you develop premature contacts over time. So what are the factors that contribute to bite instability? Of course, the stability of the TMJs, the upper cervical spine, the periostatus. All right, these are 5 factors that can contribute to bite instability. So let's talk about the TMJ first and then the upper cervical spine. So again, the starting point of a stable occlusion really is the TMJs, and if that's not stable, then of course you'll have bite instability. So we know when we bite down, that disc should cover the entire bone, all right, and that lends to a joint dimension, and that's a relatively stable joint. But when the joint becomes unstable, what happens really? We have the disc that becomes displaced, right? We have the joint space that becomes reduced, and what's happening to the condyle. So these are the 3 things that occur within the TMJ, and what effect does that have on the system? So again, we are constantly changing and constantly adapting. We are constantly changing and constantly adapting as a system. Right? When we lose dimension of the joint and when we have a disc displacement, that can have an impact on lower face height dimension. Okay, the lower face height could either decrease, the lower face height could either increase, or the lower face height can remain the same. Okay, so I teach my residents the first thing they should do is look at lower face height. Are there any changes that occur, and what does that really mean? So many years ago, I developed a face type classification system that I've shared many times in our community for us to look at a certain face and determine what's happening within the TMJ themselves. So there's 4 different face types, the adaptive and non-adaptive. We're not going to get into that tonight fully. But I want to talk about the adaptive profile, and later we'll talk about the restoration of an adaptive patient versus a non-adaptive patient. So with an adaptive profile, you have an injury within the TMJs, and the patients will have thick muscle mass, normal ligament tone, and normal bone structure, and they will change in a certain way. They'll have a decrease in lower face height dimension because you're losing the joint dimension. They'll have a thickening of the masseter muscle. So if you lose vertical, you will gain horizontal. So you'll have masseter hypertrophy and a decrease in lower face height dimension. Intraorally, the body will do everything it can to keep the teeth together, and that includes clenching. Clenching may be physiological and not pathological. The physiological clenchers may not need a night guard, so you just don't throw pieces of plastic between someone's teeth. All right? So teeth can migrate, teeth can intrude, teeth can break, porcelain can break. That's all part of adaptation. The second type is the same occurrence can happen within the TMJs, and these patients will have thinner muscle mass and ligament laxity, and they cannot change, they cannot intrude their teeth. They'll develop an increase in lower face height dimension and high angle mandible, and their teeth will separate. Their teeth will separate over time, and they'll say, you know, doc, I spit at people when I speak. I can't bite into a slice of pizza anymore. Okay, this is not because of tongue thrusting. Sometimes you can have an acquired tongue thrust, but this is happening because the TMJs are breaking down at a rate faster than the body can adapt. So how do we evaluate the TMJs? By understanding the occlusion, something that we see in our practices every day. Granted, you're not going to take MRIs, you're not going to do all that, but we do look at occlusion. We need to understand occlusion. So as general dentists, we want to know, are we dealing with a stable joint or an unstable joint before you put that dentistry in, 3-unit bridge, even a single unit crown, or even more? Are we dealing with a stable environment or an unstable environment? So in this particular case, if you have clicking and even pain, all right, and not locking, but if you just have some clicking, but if we see this manifestation in the occlusion where we have cusp tip wear only, that is a stable joint. This is not a case that, oh, you're wearing your teeth, you need a night guard, right? So the joint may be clicking, but only on the lateral aspect only, but this could be a stable joint. You can perform your dentistry with this. Now, wear is desirable to maintain a balance of this demagnetic system. Okay, we see wear here. This could be a stable scenario as well. So if you're losing dimension of the teeth, you could buttress the bone. So the bone is actually growing, maintaining the lower face height dimension. So if we see this scenario, that might be a stable situation as well. Okay, so we'll look at these particular cases and say, oh, you're grinding your teeth, you must be under stress, you need a night guard. That may not be true. All right? So wear is something that happens physiologically and may be pathological as well. That's for another lecture as well. But why do bites change? Why do we see bites changing? Where we have anterior uncoupling and different changes. All right? Now again, remember that the unstable joint will lead to unstable occlusion. So if your bite is changing, you're dealing with an unstable joint. You want to be careful before you put that roundhouse dentistry in. Okay? So we know that the occlusion really is the window to what may be happening within the TMJs. If you see uncoupling like this, or separation in the anterior teeth, that may be a clear sign that you have a joint problem and an unstable situation. So our current concepts are that if we have dimension loss in the back of the system, that can manifest in either the posterior teeth or in the anterior teeth themselves. So look at this particular patient. We checked her in MIP, normal bite. And we also checked her in a fully seated condylar position. That's bimanual manipulation to the first point of contact. That's seating the condyle. Maybe you were trained as CR, all right? I'm a Dawson trained person as well, but we don't call it CR. So this is an unstable situation. If we see this situation, we're dealing with joint structural problems, all right? Clearly a joint problem. So we check our patients at MIP and the fully seated condylar position to determine, are we dealing with a stable or unstable joint? Okay, here's another case, MIP, fully seated condylar position. We can see a shifting, right? And clearly when this person is imaged, we could see that there's a definite instability within the TMJs, and even in the right side, we have bone pathology. So this is an indication that we have joint pathology going on. So the next factor that we could talk about is really the upper cervical spine, and this is where I live in dentistry mainly, all right? It's the most misdiagnosed and misunderstood region in our body, but it does affect us, all right? The head sits over the spine at the atlas bone. It's the most movable bone we have in our spine, so we want that head to be vertical over the spine. That means the atlas should be horizontal. But when we experience trauma, a trip, a fall, a sports-related injury, a whiplash, we can have a misalignment of the atlas bone, and that head is not sitting straight over the spine. We call that a craniocervical junction disorder, an atlas misalignment, or even a whiplash. Okay. So our goal is to get that head to sit back over the spine. There are many ways to address this: physical therapy, TENS, chiropractic adjustments, home exercises, and so forth. Okay, how do we treat the neck? Now, we're a dentist, why do I care about the neck? Well, I do care about the neck because there's a lot of facial pain from the upper cervical spine that we really don't understand. It's not really understood, and I understand it. In our particular practice, we treat with atlas orthogonal therapy. It's instrument-based, it's mathematical, there's no manipulation, no cracking and popping, it's all instrument-based. When dealing with occlusion, right, if you look in the pre-treatment, look at the angle of the atlas and the angle of the incisal edges. Right? So if that head is off, right, the maxilla is also going to be tilted and the mandible will not track properly. But when you put that head back over the spine, right, the atlas flattens out and the incisal edges and the maxilla will flatten out, and now that that mandible will track differently too. So yes, it does have an impact on occlusion. So Dr. Colavita and I have been practicing for 20 years. We're the first and only practice in the country to combine our therapies, and we've helped so many people. We can't help everyone, but we've helped so many people together that we couldn't help alone. If you're interested in what we do, you can go to my website, drlewisvita.com, and we have some videos, or you're welcome to come to my office, all right, and we can explain what we do here. Now, we know that implant occlusion should be reevaluated and adjusted continuously. So this is a case of an adaptive occlusion scheme, okay? Now look at her panorex. When we look at her, we look at the antegonial notching. When we see antegonial notching like that, we know that there's a big, thick masseter sling, and this is a patient that is adapting, and we have that thickness in the masseter region as well. Now, when we image this particular person, we see that there's joint instability. The TMJs are not stable, the disc is displaced, they're functioning on retrodiscal spongy tissue. And over time, you will develop premature contacts in the posterior region. Look at the screw-retained implant crown that had a fracture of the porcelain. Okay, that's part of adaptation as well. This is one of my cases, and one of my many cases. Okay, so this is a patient that came to me, okay, and we did a 2-unit implant crowns, all right, and upon return, all right, we evaluated his bite, and he developed premature contacts again, all right, but when he was imaged, his joint was not stable, the disc was displaced, and he had joint dimension loss, so yes, we had to go in and reestablish our implant protected occlusion, very common, right? So we have our implant protected occlusion that has to be continually monitored and readjusted throughout. Here's another case with multiple implants in both arches. Okay, she developed the incline interferences, right, which had to be reestablished. Okay, so yes, every time a patient comes in for a recall visit, a hygiene visit, whatever you want to call it, we do check to make sure that their implant protected occlusion is remaining stable, or do I have to go in there and tweak it again? So a little something on surface wear of teeth, because I want to talk about bruxism. All right, we look at this and we say, oh, you know, you're grinding your teeth, and we have some serious wear. We see this in our practices. But wear is a normal physiological event. It's a prevalent condition. Not everybody that wears has a pathological situation. Now remember, we are constantly changing and constantly adapting as a system. So let's get back to our proven principles that we're getting away from. The loss of tooth surface is undesirable, but a normal physiologic event. Look at this particular person. Look at the significant wear of this particular person. But look at the bone, the alveolar bone, how it's buttressing, how it's growing, right, to maintain the adaptation of that significant loss. So this patient does not lose any lower face height, does not lose any function. Not everybody can do that, but we have to identify those that can. So we have our proven principles in that it's a phenomenon where teeth will wear as part of adaptation. Okay, something has to give. Right? And it's the teeth that are giving because they're the sacrificial devices. I tell patients, it's like, if I punch the wall, either my hands are going to break or the wall's going to break. Something has to give. So the teeth are really the sacrificial device of the stomatognathic system. So if you have joint dimension loss and issues in the back of the system, that can manifest not only in the front of the system, but in the molars. I show this all the time. I don't know how clear it is, all right? But this is a 17-year-old female that has significant wear on her molar teeth, and I still told this patient, Mom, this is a TMJ problem, right? Look at the significant wear. This is not from clenching and grinding and stress. This is adaptation. When we imaged her, she in fact did have a TMJ issue. Right? Again, over and over again. Look at number 18 and number 15, how worn these teeth are. Fractured fillings, worn dentition, intrusion of teeth, adaptation. This is part of adaptation. Right? When we image this particular person, look at the significant changes in the left condyle. So we have condylar loss, we have joint dimension loss, and the teeth are wearing as part of adaptation. So we look at this, and is this a physiological or pathological event with all this wear? You know, you would look at this and say, you definitely need a night guard. But if this is a physiologic bruxer without symptoms, and you put a night guard in this patient's mouth, they will have symptoms that they do not normally have. They'll grind very hard on this particular guard. They'll throw it out in the middle of the night. And they'll be mad at you because they spent all this money and they didn't have any symptoms to begin with, but you convinced them that they're wearing their teeth out. All right? So we have to be very careful with that. Okay? So I'd be more than happy to come back and just focus on bruxism and occlusal guard designs and things like that. So let's talk a little bit about bruxism and implants. Okay, bruxism is a parafunctional habit that's related to complications of dental implants, and that's because of excessive occlusal overload. We know that, just think about that. All right, and Mish talked about this way back when, that we need to identify patients that are bruxers and deal with them when we perform our implant dentistry. Causes of implant failure, again, bruxism is recognized as the most significant factor, right, because of occlusal overload, excessive forces. There are many studies during my training that if we would measure a bite force during the day, say 300 psi's at night, that can go up to 900. So the bite force at night is significant in these bruxers, significant. So we have to be careful not just to throw any kinds of pieces of plastic between their teeth. And Glauser found that 41% of implant failures in bruxers themselves. So we're talking about daytime clenchers and nighttime bruxers and occlusal overloading as a cause of implant failure, okay? And especially the daytime clenchers. And with daytime clenchers, they'll cause lateral forces on the teeth and non-axial forces. So although bruxism increases the risk of dental implant failure, just because a patient grinds your teeth doesn't mean that they should not have an implant, okay? And many studies says, well, we should throw pieces of plastic between their teeth. So what's really appropriate when we're dealing with occlusal guards, right? I like a full arch guard as opposed to a partial arch guard. So we want full arch of appropriate thickness and equal contact. There's no two guards I make that are exactly the same. It's not an arbitrary number. Take impressions, make me a 2 millimeter guard. That's not acceptable, that's not appropriate, all right? Everybody in my practice is imaged, and sometimes I image with or without the guard, so that will give me an idea as to how thick that guard should be. So this is a typical permissive splint. I like the upper arch, right? Full arch, flat planed, of appropriate thickness that has a purpose, Okay, so we're dealing with occlusal load issues. That's really what we've been talking about, occlusal load, okay? So part of implant failure, the most common complication is fracturing of the porcelain. Now, fracturing of the porcelain. So we see this all the time, okay? Now this even occurs in our ceramic materials. You say, well, I have a ceramic material. It doesn't fracture. Well, that's not true, because the ceramic material has to have a certain thickness. If it's not thick enough and it's weak, it'll also fracture. So let's talk a little bit about restorative dentistry. So we talked about the top of the system being the joint, the bottom of the system being the implant body. What goes in between? That's our field, okay? We have the surgeon put the implant in, all right? We evaluate the jaw joint. Now, what kind of crown are we going to place over the implant body, right? And it's not one size fits all. But I assure you, let's go back to dental school years, okay? I always love talking like this, all right? The properties of an ideal restorative material, I'm sure we all forgot this, okay? Wear resistant, equivalent to or lower than enamel. We want no fatigue over time and function, and we want fracture proof in dimensions of 1 millimeter or less. What material really fits this? Gold. Gold. Right? I was trained with gold. I do a lot of gold in my practice. The younger dentists do not. They're not even trained. They're not even trained with amalgam. How sad is that? Okay? So we know that gold is the kindest material and it wears approximately at the same rate as enamel. So we have our proven principles. It's been in our field for hundreds of years and proven. Right? Why are we getting away from that? We know that the wear of a restoration must always be related to the stomatognathtic system in which the restoration has to function. The wear of the restoration must always be related to the system in which it has to function. Okay? And gold really has fit the standard. Right? But we have current trends in dentistry for years and years. Our profession is trying to develop restorative materials that function like gold with better aesthetics and better fee. Okay, that's what we're doing. We have the standard, we have the best possible material that functions in our system, but we don't want it anymore. We want to have something that's white and not cost as much. So let's talk about flexural strength, because I think this is what it's all about when we develop these ceramic materials. Flexural strength, of course, the material's ability to resist deformation under load. Flexural strength of enamel is 100 to 200 megapascals. Enamel, 100 to 200 megapascals. Okay? A gold crown is 100 megapascals. Right? That's why it functions well. Right? Enamel, gold. We know the PFMs are 150. We know the PFZs are up to 720. We know the EMAX can be up to 400. But look at monolithic zirconia. How popular is that? Is this appropriate in a system that is changing? Right? Up to 1400 megapascals. So let's compare what the literature is really telling us, because our literature is really telling us something different. You have to understand what you're reading. The monolithic zirconia crown, if highly, highly polished, the monolithic zirconia crown could wear enamel better than enamel wears enamel. Right? That's what's confusing about our literature. Okay? If highly polished, it wears against enamel like enamel wears enamel. But it will always crack and fracture the opposing enamel. So if it's highly polished, it'll wear very well, but it will always crack the opposing enamel. If it's not highly polished, then the zirconia becomes a significant wear of the opposing enamel. It will wear. It will wear and crack. Okay? Now, if unpolished and just glazed, it becomes the most abrasive material we have. Now, I can't determine if I'm looking at a monolithic zirconium crown if that's glazed or polished or highly polished. Now, Mark's not here, he owns the lab. I was going to ask him that question. Is this lab really highly polished this? Or if you're doing it in-house, are you spending the time polishing like you're supposed to? So if it's not polished properly, right, or just glazed, it's a very, very abrasive material. Right? So our trends in dentistry is we want white, we want cheap, and we want unbreakable. But we're not unbreakable. Right? It doesn't fit into the stomatognathtic system. Okay? So, I took this out of Glidewell's book. Okay, this is a Glidewell picture. Okay, so you have a PFM that's fractured in the porcelain over time. Why did that PFM fracture? Well, that's part of adaptation. It had to give. Something had to give. But in the same picture, it showed gold with beautiful wear. So if you have that situation, would a monolithic zirconia crown really be appropriate? All right, since this has worn and needed to change, would you put something that's unchangeable? And what effect would that have on the system itself? So really, how does zirconia interact with the masticatory system? So more than 10, maybe 15 years ago, I did a little in-house study, all right, because it was becoming very popular, and I said, well, let me see what I could do with this monolithic zirconia myself. So this is tooth number 15 that was functioning very well. It was a gold crown, probably had for 20 years. Tooth number 18, I put a monolithic zirconia crown, and on the first recall, look what happened to it. It beat the heck out of it, put a hole in it, beat the hell out of it. Okay? So look at this gold crown that functioned very well for many years, and I put a tooth opposing that with monolithic zirconia. Of course, they had to be changed over time. all right, and look at how that significantly warns that situation, all right. PFM, tooth number 2, 31, monolithic zirconia, fractured of the porcelain, okay. We have PFMs that function very well, were very stable for many years. I put a monolithic zirconia crown, look how it beat the heck out of that. So something has to give. They're unlike materials, okay, unlike materials. So this is a case that came to me, big, strong, weightlifting type of guy. He came to me, he had pain and swelling in the lower right quadrant. I took an x-ray, it's very obvious what we're looking at here, probably a fractured root, okay? So I was able to get his pre-treatment images, and obviously he has a lot of dental pathology in the upper right quadrant, and look at the pre-treatment x-ray of that too. The dentist placed a 4-unit monolithic zirconia bridge in the upper right quadrant, and this is how it came to me. Okay, something had to give. All right, this is obviously occlusive trauma, fractured the root. Right, it doesn't wear properly. Right, who knows if it was polished, unpolished? I don't know, but it certainly caused significant occlusive trauma. So we are a dynamic system. We are a system that's ever changing. This is one of the great slides for me. Our system is constantly changing. We can't avoid it as we get older. Right? The system is constantly adapting. Our restorations must also adapt. Our restorations must also adapt. So let's place restorations into the system, the stematognathic system, that can adapt and not create a lot of issues. So our restorative considerations, so I've become very concerned about this type of scenario where we have monolithic zirconia, all right, these roundhouse monolithic zirconia prosthesis, all right, and it has to, the implants themselves have to provide all the 5 variables of occlusion. They're not shared with their natural teeth. What will this actually do to the implant itself, the implant bone interface? Just think about that. So, Gordon Christensen, reported that 82% of single-unit crowns are zirconia, all right? And most common single-unit implant crown is that screw-mentable, right? But cast gold is still the only long-term proven material for Bruxer. So when Glidewell says, give me a Bruxer crown, and they smash it with a hammer, okay, you'll say, oh, that's great. That can't be great. That can't be great, okay? So we are not the same. Something has to give. Okay, so let's quickly go through some scenarios, all right? So under normal circumstances, we want the teeth, the joint, and the muscles to function properly. So we have changes that occur within the TMJ. That's the starting point. Okay, that's the starting point. If we have an adaptive patient, thick muscle mass, all right, they can intrude their teeth. The teeth have to move to get out of the way. Okay, they're very adaptive. All right, what happens to the dentition? All right, so we have the TMJs that are changing, but they have thick muscle mass. The teeth will wear, the teeth will intrude, they'll migrate and fracture. They'll do everything they can to maintain the balance and to maintain the asymptomatic nature of the patient. It's the stematognathic system. Okay, this becomes a sacrificial device. This is normal. If we had that same patient and they require crowns and we put gold over gold or gold over a natural tooth, we'll have the wear of the restorations, but they'll maintain the joint and muscle harmony. There will not be any destruction to the system. In the same type of patient, if we have a natural tooth over PFM or a PFM over PFM, what will really happen? Well, over time, that porcelain can fracture because something has to give. Remember, we have bite forces in the adaptive profile. Okay? If we have the adaptive profile, we have a natural tooth over an implant with a PFM, what could really happen to the system? Well, we could have wear of the opposing, widened periodontal ligament space, and we could have the porcelain can develop problems. Okay? In the same case, if we have a natural tooth over a zirconia crown, we put a zirconia crown in an adaptive patient. What can happen? We'll have significant wear of the opposing. We'll have periodontal compromise. We'll have intrusion. We could have surface fracture. Here's a 36-year-old male that came to me for TMJ issues, right? And we imaged him and he had instability within the TMJs, the disc was displaced. He was functioning on retrodiscal tissue. Number 15 and 14 were treated with monolithic zirconium crowns. I don't know if you could see this, but look at the significant wear pattern of 18 and 19. That's not a normal wear pattern. Look at how those teeth were just beat up from the monolithic zirconia restorations. So in the adaptive patient, if we have a natural tooth over an implant with a zirconia crown, implant with a zirconia crown, that's kind of the standard today in dentistry, right? So what will we have? We could have fracture of the tooth above it, we could have periodontal compromise, and we can increase the occlusal load to the implant bone because that's not going to give. So as the bite is trying to change, we can get an increased load to the bone. If we have a natural tooth against a gold crown on an implant, no, what can we have? We'll have wear of the restoration, and we'll have no increase in load to the implant, and we'll maintain harmony. Okay. So a typical scenario, we have implant crown, zirconia crown over implants, all right? All the load is transferred to the bone. The restorations will not wear. They become daytime clenchers. Right? These patients will come to me and say, I was fine until I had that crown in place. Okay? Now we have the non-adaptive patients. These patients cannot wear their teeth properly. They don't have the power. They'll separate in the anterior dentition. Right? And naturally, they will fulcrum off the back teeth, and they will have anterior uncoupling because the joint breaks down faster than the teeth can adapt. That's what naturally happens. If we have a natural tooth against an implant with a zirconia crown, what do you think can happen? We could have a strain to the whole system. We could have occlusal interferences. We could have compromise. Right? But if we put a gold crown over the implant in the non-adaptive patient, right, the gold crown will wear will have less chance of developing all these symptoms. So we have to understand this. So yes, in second molars, in a non-adaptive patient, I only offer gold. Say, well, I don't want gold. I'm going to give you gold, all right, because I know it's better for you. Okay. So we have a non-adaptive patient with a zirconia crown and a natural tooth. We have no intrusion. We have potential for increasing more of the open bite. And we have dental pain. Okay, so here's a non-adaptive patient. We check them in MIP in a fully seated position. Okay, they have a monolithic zirconia crown at number 14, and look at the significant wear of that opposing tooth. Very significant wear. We have a natural tooth against zirconia. We have zirconia against zirconia crown, and the non-adaptive patient will start to open up more in the anterior region because we're fulcruming off the back teeth. And the worst possible scenario in a non-adaptive patient will have implants and zirconia crowns opposing each other, and we'll have complete neuromuscular adaptation, periodontal compromise, and increase in uncoupling. So I want to end with this particular case. There's a 31-year-old female that came to me with TMJ problems, right? She couldn't open her mouth. She had left TMJ region pain, jaw locking, and so forth. Right? Her history was significant for multiple traumas. And the onset of her symptoms was after she had root canals and crowns placed in the upper left and lower left quadrant, 15 and 18. And then she became symptomatic. So what do we really see in a non-adaptive patient? We have sloping of their shoulders, forward head posture, high angle mandible, increased lower face height. So just by looking at her, we know that she's a non-adaptive patient. We look at her MIP, fully seated, condylar position, and protrusive. Look at the edge-to-edge position of the protrusive, right? She's riding off of the posterior molars and not off the anterior teeth. When she was imaged, she had significant pathology in the left TMJs with the disc being displaced and the bone breakdown. The root canals did not cause that. These crowns did not cause that, I assure you, but it unmasked the problem. It unmasked the problem. So look, we had 15, so we had full contour zirconia, and look at the bone. Look what happened to the bone. All the forces were transferred to the bone itself. Okay, so what we had here, all right, is Zirconia was definitely contraindicated in a non-adaptive patient. We have no way. Okay? So eventually that tooth was extracted. She had TMJ surgery. Right? Because of that, the tooth was extracted, an implant was placed, and we went from the monolithic zirconia to a gold crown. Okay, on both. Okay. Here's our reference list. And I thank you for your time. If you have any questions. Okay?